Welcome to the Saving Lives podcast. I'm Eddie Joe. Today we're going to be discussing sleep and delirium in our critically ill patients. And the study that I'm going to be using as a reference for today's episode is titled Effectiveness of Sleep Interventions to Reduce Delirium in Critically Ill Patients, a Systematic Review and Meta-Analysis. It was published in the journal Critical Care on June of 2023. As always, this is not medical advice. Please read these data for yourself. The citation is in the show notes down below. And as always, hat tip to the authors. A quick plug for my book, the Vasopressor Inotrope Handbook. If you haven't picked up a copy yet, go ahead and do so. Thank you so much for your support. It's available on Amazon, and you can save 10% if you buy it directly from me on my Shopify account by using the code podcast. So let's get started talking a little bit about delirium. Although with the population of people who check out my podcast, you guys all quite know what delirium is. But the reality is that if you look at the definition, it's acute cognitive dysfunction affecting up to 80%. This number is always crazy of mechanically ventilated ICU patients. And it's associated with increased mortality. Patients end up staying in the ICU a little bit longer. Patients' families, appropriately so, start to panic a little bit, as well as long-term cognitive decline. So that's something a little bit hard for us in the ICU to assess because, once these patients get out of the ICU, chances are we'll never see them again. Now, discussing sleep, as all of us in healthcare struggle with sleep, I'm sure it's critical for recovery in our patients. Doing fun things such as checking labs at 5 a.m. and chest x-rays at 4 o'clock and blood glucoses every 1 hour isn't good for sleep. So that's the reason why our patients in the ICU don't get rest, not to mention that their lights, their monitor buzzers, helicopters landing in our respective hospitals, staff chatting outside, etc. So all these things kind of make our patients crazy, for lack of a better term. So the objective of these authors was to evaluate the effectiveness of different sleep interventions to try to reduce the incidence and duration of delirium in the ICU patients. So what they did here was a systematic review and meta-analysis. What they did is they included 15 randomized controlled trials with a total of 5,041 patients. So a bunch of patients across the medical, surgical, as well as mixed ICUs. So here are the interventions that they used to try to tease out if there were benefits. From a pharmacological perspective, they used dexmedetomidine, brand name is Precedex. They also use melatonin and rometilon. I can never say that word properly. From a non-pharmacological perspective, they use earplugs, eye masks, light therapy, and multi-component intervention. So the outcomes that these authors were trying to get to were, as a primary outcome, was the incidence as well as duration of delirium. From a secondary outcome perspective, they wanted to assess the sleep quality of the patients, ICU length of stay, and lastly, but no less important, is mortality. So what did they find? From their primary finding of overall effectiveness, they found that using sleep interventions in general did reduce the risk of delirium by 27%, which is fantastic. And it also led to significant reduction in ICU delirium incidence in patients that were receiving interventions compared to those who received controls, or better yet, nothing. Now, from an actual treatment standpoint, they found that the dexmedetomidine was the one that had the most robust effect, reducing delirium incidence by 57%. I don't know how I feel about this because, we use dexmedetomidine quite a bit for better or worse in our patients, and I can't say it's a delirium cure per se. But anyway, that's what they concluded here. But they also saw that dexmedetomidine did short ICU stays by about 0.41 days. From the non-pharmacological interventions, including the earplugs, eye masks, and light therapy, these all had inconsistent results. Now, the multi-component interventions, they showed promise, but it wasn't statistically significant. From a medication perspective, the melatonin and rometilon, I can't say that word correctly, I'm sorry. These did not have any benefits when it came to reducing delirium or improving sleep quality in our patients. Now, they did go ahead and do a subgroup analysis of these patients, and really there was no difference in delirium reduction across the different ICU types or intervention categories. And so, we're kind of left a little bit bummed out because we don't have that cure-all. Now, these authors did go ahead and give us some recommendations for practice and some things to think about. First of all, with dexmedetomidine, they stated that it could be effective in promoting natural sleep cycles and reducing delirium risk. And so they thought that it could possibly be integrated into sedation protocols, especially for patients who are at high risk for delirium, which in reality is everybody who's on a vent. The challenges that they found from a non-pharmacologic standpoint is that, they can't always get rid of the ICU noise, the ICU light, as well as frequent interventions or interruptions that could limit the effectiveness of these treatments. Now, they suggest having environments that are a little bit more conducive for sleep. However, we all know our ICUs. We're not moving to new buildings anytime soon. That's very idealistic. There was a paper a couple months ago, or maybe over a year ago now, that had like the optimal ICU that had like a hotel entrance, and then it had the hospital entrance for the room, and the separate door where the food would come in, and there was a garden, and there was natural light that came into every room. And I just thought to myself that utopia does not exist. But anyway, it's nice to think about, and I guess it's pretty cool if you could publish it in a big journal, somebody will pick it up. But either way, so there were a lot of limitations out of these 15 studies, which include the fact that there was high variability in sleep assessment methods across the studies. So how they find sleep on one study is not the same as the other. And there's also publication bias and overall limited evidence on long-term outcomes of these sleep interventions. I don't know about you, but I don't follow up with my patients once they leave the ICU, unless they end up coming back for a different hospitalization a couple of years later, which is kind of bittersweet because I like seeing these folks, but I just don't want to see them at the hospital. I tell them that they'll either see Publix or Costco, which are the two main places that I go to when I'm not at work. So I'd like to know what your thoughts are. Do you have this fantastic response with dexmedetomidine that you've seen a great decrease in delirium incidence like they do here? Do you sprinkle melatonin into all your patients? I'm not even going to try to say that other medication that starts with the letter R. Or does your institution use eye mask, earplugs, or things of that nature? Let me know what you guys do in the comments. Thank you so much for tuning into another episode of a Saving Lives podcast, and thanks for everybody who has picked up a copy of my book, The Vasopressor Inotrope Handbook. I greatly appreciate your support. I hope you all have a wonderful day and a wonderful Christmas and a very happy New Year. Thanks for your support, guys. Have a great day. Bye.